We're at the 22nd CROI. I'm Schaich with IFARA, and I have with me a distinguished panel of speakers and presenters and poster presenters and who have participated in this year's CROI. And this panel is about cardiovascular disease and possibly the future, where we're going with this field. We have Jorge, Monica, Stephen, and Nina, all who will tell a little bit about what they brought to the CROI and maybe some of what you take away from the CROI, because the CROI is almost over at this point. So let's start on the other end there with Jorge and speak to what you're bringing to this particular meeting.
Okay, excellent. Thank you for the invitation. I came to present a poster and participate in a theme discussion of novel ways of predict cardiovascular outcomes in patients with HIV. And what we did was looking at commonly routinely obtained measures such as HIV viral load, CD4 counts, as well as some other parameters such as hemoglobin, creatinine, hepatitis C status, etc., and look at it in a cumulative way, look at the whole history of it. And we wanted to see if doing so, looking at things in that fashion, would do a better job than just cross-sectional measures, and it did in the VAX cohort.
So what was the outcome? Can you kind of describe some of the outcomes?
We were interested in myocardial infarctions in people starting antiretroviral therapy in the VA system. And we looked at it from the year 2000 through 2012. And we used Medicare and VA ICD-9 codes to do so. And
you are with the VA?
I am with the Atlanta VA Hospital and with Emory University.
Okay. And Monica?
Well, thanks. My name is Monica Shah. I'm with the National Heart, Lung, and Blood Institute, and my role there is I'm the NHLBI AIDS coordinator. So my role is to really stimulate research in HIV-related heart, lung, and blood disease, and in particular, my area of interest is cardiology. I'm a cardiologist. So what I presented today was actually a look at our portfolio and some of the interesting work that's being funded through the NHLBI AIDS program. One of the major studies that we're funding this year is the REPRIEVE trial. Dr. Grinspoon will be talking about that in a few minutes, I'm sure. But we've also done a lot of really other interesting work ranging from genomics to the microbiome, lung-related disease, sickle cell disease. Our portfolio has really grown over the past year. And one of the big things that we're really trying to promote is multidisciplinary collaboration between HIV investigators and cardiologists, pulmonologists, blood hematologists. So we're really trying to get people from multiple different disciplines to work together to advance the field.
These are HIV, in the HIV field, there's a lot of cardiologists, but there are others outside that may have important information that could generate new collaborations.
Well, that's really interesting. You know, we actually have a lot of HIV investigators who are interested in cardiovascular disease, but the cardiovascular community themselves has been relatively slow to come on board and to research in this area. So what we really want to do is bring these communities together. Obviously, the HIV investigators have expertise in HIV. The cardiovascular researchers, that's their field, so they know the new imaging techniques, they know all the latest cardiovascular research approaches, and so our goal as a funding institute, as a research institute, is to bring multiple people together.
Multiple disciplinary.
Yes.
Yeah. And Stephen, you want to talk about?
Yes. So my name is Steve Grinspoon, and I'm an endocrinologist, but I've been involved in the cardiovascular metabolic complications of HIV for a long time now. And I would say over the last 10 years, we've been focusing on cardiovascular disease per se. And as I mentioned in my talk today, we really determined that it's a unique disease in HIV, that it's a disease that's characterized by atypical plaque, vulnerable plaque, high-risk morphology, inflamed plaque, and that this occurs even among patients with low traditional risk scores. And so that is interesting information, but it does present a challenge as to how to treat it. One of the things that we've been working and very grateful to NIH for is their funding of a large trial, the first trial and the biggest trial, to try and once and for all come up with a prevention strategy for cardiac disease and HIV. And that's very important because the cardiovascular myocardial infarction rates in HIV are about 50 to 75% higher, and it remains a stubbornly high cause of mortality. And so we have launched, based on some preliminary data that we presented today on the efficacy of statins on plaque, we've launched a large prevention trial to reduce cardiac events, MI, stroke, etc. And embedded within that is a mechanistic sub-study to learn why statins might work, whether they work through lowering of lipid levels or lowering, decreasing of plaque or improvement of plaque morphology. And as Monica was saying, we really look toward bringing in people from multiple disciplines into the study. We've already benefited tremendously from having a very large working group with HIV people, clinicians, endocrinologists, cardiologists, epidemiologists, biostatisticians. It's been a lot of teamwork, and we're very excited to launch REPRIEVE in the near future.
And we will put some information about that up on the screen as well.
Great.
Here
Yeah.
Great.
And so how does that mix in with aging? Because I know, will you have any sub-study or component of that that will define the difference between people who are aging and people who are not, or?
Not per se in REPRIEVE, but I think a lot of the work, well, we'll always be able to analyze whether there are differential effects among older or younger people of statins. That's true, but it's not designed specifically to look at aging per se. But I think the question in that regard is whether this subtle underlying inflammation that we've all shown to be persistent, perhaps through persistent virus or the body's attempt to fight the virus, whether that subtle inflammation in the background promotes an aging phenotype in HIV patients. You know, more kidney disease, more liver disease, more heart disease, more neurocognitive disease. And that may be the case. I don't think it's been proven definitively, but it's interesting to speculate. And one interesting thing about REPRIEVE is that it's not only going to look at heart disease, but it has secondary endpoints: liver, kidney, even HIV, and it's perhaps by lowering some of this inflammatory milieu, it'll have positive effects on these secondary endpoints. So REPRIEVE is kind of a model, if you will, in an inflammatory condition to look at both primary cardiac endpoints and secondary inflammatory endpoints.
Okay. And Nina?
So I'm an ID physician.
Give me your full name because
Nina Friis-Moller from Odense University Hospital in Denmark.
Only you can say that.
Yeah, I think that's right. And so I'm an ID physician with a background in epidemiology, and I was here today to convene the session on prediction models for cardiovascular risk in HIV patients. And I've been working on developing prediction models based on the multi-cohort study, the DAD study, which includes cohorts from Europe, Australia, and the United States. And we have recently updated our earlier work. I think what I'm also seeing in the clinic is really the aging of our patients, and with that a number of comorbidities, including more cardiovascular disease outcomes now. So aging may be one of the most dominating factors. So
differentially from those who are not HIV, or do you show that?
In our prediction models, we saw some data to suggest that perhaps in today's presentations in our session, we saw then that the US cohorts that assessed our prediction models and other prediction models, they found the rates of cardiovascular disease to be higher than estimated from prediction scores, suggesting that there could be other factors in play. Could be the underlying inflammation, and that may add more to people as they are aging.
Would that be additive, or?
These models are multiplicative, but how these factors interact is not really known.
So do you have, so if it's I guess, so the aging issue is kind of concerning, because I know that we thought originally that anyone living with AIDS would be, have this aging effect. Whether you're young, you have a certain percentage of, you have a certain differentially more focused area. You're going more in a heavier direction towards AIDS than towards aging than those who are not HIV. And no matter what your age, but I think now we're seeing more, it seems to be in those that are in, say, plus 65 or plus 70, there seems to be more differential effect. And I didn't know whether this was reflective in the cardiovascular population, those that were dealing with cardiovascular issues.
I think it may depend on which demographic background you live in, and other factors as well, such as lifestyle.
It would be more dynamic and more influential, or more affected. Yeah.
Some of the studies that were presented today and some of the prior studies do suggest a greater discrepancy in MI rates between older patients, HIV to non, than younger patients. So, for example, the curves start to splay out among older patients. Yeah. And an interesting point was the Trion study today. I believe that the discrepancy between observed and predicted was greater with greater age. So some of those studies may hint at a multiplicative effect, if you will, of aging upon this excess risk.
And so it's not I guess at a certain point you get older and you also have these hits that you take from HIV,
yes, and it
becomes more profound for the older people, but the younger people can endure
they still have hits, but they can endure it a little bit
better. Yeah. And that's kind of what I've been seeing too. I feel that this is, so having said that, and I know that maybe you can't answer this question, but my suspicion is that I work hard. I'm 68. I work hard at trying to stay fit. Yes, I've had an open heart surgery just recently, 8 weeks out from that. But
you look great.
Yeah, but I don't look as good as I could, but I feel great. But it is the idea in my mind that I work out, exercise, good, nutrition where I can, the conference has afforded me the best nutrition, but, unfortunately. But where I can, I try to do the best I can for nutrition. So it seems as though that going into the cardiovascular event that I had, this open heart surgery, being very healthy was a really good thing for me, because I came out on the other end with shining colors. So I am working hard to develop programs for people living with chronic disease, as well as HIV and cardiovascular issues, to support each other in support groups, because we don't have the way to afford that kind of thing being paid for, such as rehab. But it seems to me that would be helpful. And I'd love to do a trial on that, but certainly a demonstration, starting out with just doing it and finding a way to get these groups together, because I think the last thing people want to do today is they think, well, I'm just so tired, I'm just going to sit down and be good to myself and not do anything, when in fact the opposite is what it is. When I go out and bicycle in the morning, I tend to find out after I'm out there a while, and that was a day that I thought, I'm not going to be able to do this. I feel like 50 miles coming back, the last 10 miles are my best. So it's burning through that wall that tells you not to do it. And people that typically say listen to their body may not be a good thing. I don't know. I'm guessing that's true.
I think you're on the right track. I think physical activity is one of the main
mainstays in certain cardiovascular, right?
Yeah.
There's also some very unique environmental risk factors in HIV, like smoking, for example. The smoking rates are higher in HIV for whatever reason, and they have a very disproportionate effect on cardiovascular rates. There was a very nice paper on AIDS by Helberg, and I think CVD rates are 7 or 8-fold higher in HIV smokers than non. Even non-cancer events are higher. Even AIDS events are higher.
We just don't take the insults as well.
Yes, exactly. And I think so. Those kind of modifiable environmental risks are, really, really important to modify. And that will certainly help the situation.
Yeah.
You really hit on a topic that I think is the HIV world does so well, and that is community empowerment and community engagement. I think really going out to the communities and talking about these types of preventive interventions, or really getting them engaged in these healthy behaviors is the key. I mean, whatever disease you're addressing, I think really getting the communities
whatever chronic disease.
Absolutely.
Yeah. So I'm hopeful that we can evidence this, and there are some things that do in a way evidence it, but doing studies on exercise and nutrition, it's hard to evaluate it because you can't blind it. It's obvious. We used to do that back in the University of Miami. We talked about mind, body, nutrition, exercise, and they were doing studies way back, I don't know, 15, 18 years ago, to try, because there's not a lot else out there.
Yeah, and I don't know that they have to be blinded.
No, they don't.
I think there's still important studies.
It's a good thing.
Yeah. But and you can do it against the norm or whatever, the natural history or whatever. But because people do, like myself, some people, there's people out there like myself that are trying to fight to be as good as you can, and sometimes people can do better than they ever would have done had they never been HIV positive, because they work their butt off and they say, I'm going to prove that I can be really healthy. And I'm one of those that does that. I know a few others, but not many. There's not a lot of us who can bump together. But it's important for me to try to maintain a certain level of health. And as you get older, getting back to that level is important, but difficult.
Absolutely.
When you're a kid,
the reserve is not there.
Yeah, the reserve is not there, and you don't have that bounce back ability. As we're talking now, the same thing. When that curve splits, you've got everyone saying, I feel terrible, and I can't get out of bed in the morning, and you go through all the things that you can and can't do. You can't do your own laundry, you can't even do your own dishes. This is bad, and it's not something that I want to see a lot of people having to deal with. To be as functional as you can, as long as you can.
It is very interesting what you mentioned, because the HIV epidemic in the U.S. Is very different in the West Coast, in the Northeast, and in the Southeast, where we have, in Atlanta, for example, a large proportion of young African American men with HIV. And with a young age sometimes come the feeling of being invincible. And people don't really think of cardiovascular events as something that could happen to them. So trying to explain or sell the fact that certain interventions, exercise, etc., will have probably a stronger protective effect on them than in other people is a little difficult. So it's a shout out to them as well, to the people working in the Southeast United States.
Just one more comment, and picking up what Monica said. The AIDS community from the very beginning has been very involved in clinical trials, and I think as a community, their involvement has really helped to define the correct antiretroviral therapy, and now their enthusiasm to participate in other trials has really been a model for other diseases, and I think it's really very refreshing. There's a kind of a community spirit to try and help each other out and participate in these trials, and it's really a wonderful aspect.
And we will have to be more altruistic as we get into trials that are about vaccines or cure research. I say that's the research, not that we're going to have a cure. We might, and we certainly hope we do. But in the fact that we may not ever have a cure, if that happens, if it doesn't happen, then we feel like they might have gone for naught. But really, the hope is really what's important. Trying to buy into that hope.
I actually want to follow up on that too. I mean, we're doing the REPRIEVE trial. We think this is such an important question to answer, whether or not statins will actually improve clinical outcomes in patients with HIV. And I think the way it's going to be, it is an ambitious trial, 6,500 patients. We're going to need the engagement of the community to help us get this trial done, to answer important questions. So I think it's absolutely critical that we engage not just physicians and investigators, but really the community, the patients, so we all work together to answer this important question.
And you want to include a diverse population.
Absolutely. Women, especially women, diverse populations. That's actually critical to the NIH.
Well, I thank you, ladies and gentlemen, and it's been a pleasure because it's important subjects that we talk about and discuss frequently, because it is cardiovascular is a key co-disease, if you will, with HIV, and it's always important to cover that. Thank you very much.
Thank you.
Thank you.
It's a pleasure.